All right. I think it's a good place to start by talking about your constituents. What are they still telling you about their own drug prices and their drug costs? What are you hearing from them?
I'm hearing that there's some prices that are ridiculous, but most often hear about how drug prices are contributing to the high cost of healthcare insurance. And I think they see that there's too much secrecy in healthcare pricing, not enough information about pricing. And I think that they feel that Congress can do something about it. And what I've read that Democrats want to do isn't a whole lot different than what Republicans want to do. I have a good working relationship with Senator Wyden, ranking Democrat on the committee I chair, the Finance Committee. And I've had conversations with House members, and I believe we have a real opportunity this time with Senator Wyden and I working together. And what I've heard from the House wants to do, that we can put together a bicameral, bipartisan legislation to drive down drug prices. In addition to what I do on the Finance Committee, we've had both leaders of the Help Committee, which has health in their H on the word help. They have some jurisdiction over it, and we've been communicating very close together, hopefully get products out of both Senator Alexander's committee, working very closely with Patty Murray, the Democrat ranking member there, and to put together a package from the two committees that can be brought up yet this year in the United States Senate floor.
So why haven't some of, one of the issues that has been around for a while, one of the pieces of legislation creates, that's basically the law where it tries to prevent brand name manufacturers from stop giving their samples to generics. That seems like low-hanging fruit. It seems like something, why does it still exist? If something like that still hasn't been able to pass, why should we be optimistic that a bigger package could be passed? Well, I guess why hasn't CREATES been passed too?
Well, obviously it came out of a committee that I chaired last time on a vote of 16-5, I believe. It's already out of the Commerce Energy Committee in the House of Representatives. Very much a bill similar to what we can get through the United States Senate, and I would expect that has enough going for it. We've even had pharmaceutical companies before our committee for hearing, and some of them said they would support it. I don't think they said that a year ago, but I think they feel the heat now to support it. Another one that comes out of the Judiciary Committee as well, that's got a lot of movement on it in the House of Representatives, is this pay for delay scheme, where a pharmaceutical company the brand name runs out, the patent runs out, then they make a deal with the generic company. If you keep your generic off the market, we will pay you X number of dollars for X number of years to do it. So you're basically keeping up the brand patent price for a longer period of time. So we have several things that we want to accomplish. One would be to get some of these schemes that keep generics off the market, to get generics on the market faster. Another one would be to have greater transparency in pricing. With transparency in pricing, you ought to get more accountability. The marketplace ought to work. The consumer, with more knowledge, ought to be able to make a better choice. And those are the things that are a combination. Now, if you say why legislation can't be passed, whether it's low-hanging fruit like CREATES, I'm not so sure that's as low-hanging as some of this other stuff we're dealing with. The schemes of PBMs, for instance. You have a list price up here. What goes into the list price? Shouldn't the public know what goes into the list price? Then you have the rebates. I think last year, $170 billion of rebates. Well, where do the rebates go? Do they benefit the consumer, the insurance company, or do they benefit the PBMs? And we ought to know that, shouldn't we? And the president way last June made a speech on prescription drug pricing. He's going to get the prices down. So already we have some regulations out by Secretary Azar to make sure that the rebate goes to the consumer. Now, he's got the authority to do that for Medicare, but doesn't have the authority to do it throughout the pricing system. And it seems to me that that's our job to make it more encompassing.
So some of the things you talked about, like the pay for delay and creates, there's a very smart law professor and health policy observer. Her name is Rachel Sachs. She's at Washington University in St. Louis. And when those things were first floated in January, it was one of those things where it's like, okay, it's great, but she said, do not mistake them for serious reforms to the underlying drivers of the drug pricing problem. Again, it goes to that those things might be helpful, but how do you actually get at the items where it'll bring drug spending down? Those might address some of the schemes that involve some funny business on the side, but will they really address what we as a nation spend on drugs? It seems like there's some healthy skepticism.
Let me give you an example. Infusion drugs is an example. And some of them now are very, very expensive, and they probably work. But when there's an incentive because the people that deliver the drug to the consumer, the healthcare professionals, if it's 6% of a $100,000 drug versus 6% of $1 million drug, you can understand there's a perverse incentive to use the $1 million drug if maybe the $100,000 drug would do the job. So you take away those perverse incentives as one way of doing it. Now, in another area, though, I want to say to you that with Medicaid, it's kind of the opposite. We ought to be looking towards, in the case of Medicaid, mostly for people that are low income, and there's a lot of life-saving things through gene therapy and other life-saving drugs that are very, very expensive. So we need to set up a Medicaid program so people on Medicaid can take advantage of that, and maybe it would be as simple as spreading out the paying for it over a long period of time instead of $1 million today, instead of maybe spread out over 5 years, as an example. But we need to make that drug or those drugs available for people that are low income.
Now, you mentioned rebates, and rebates are, it's the dollars between that come up when a drug manufacturer and a pharmacy benefit manager, they negotiate a price, drug manufacturer pays a rebate to gain formulary access, to be on a higher preferred list. And you alluded to a rule that's pending out there, this drug rebate rule from the Trump administration, hasn't been solidified yet. You had a hearing earlier this year with the 7 pharmaceutical CEOs and executives, and I remember you asked them, was your last question, will you lower your drug prices if this thing comes to fruition? And a lot of them said, oh yeah, sure. Some of them hedged quite a bit, like, oh yeah, but only if it also occurs in commercial. Do you believe them?
No. So let me let's go back. At this point, there's kind of finger pointing. You know, the PBMs blame the pharmaceutical companies. A month before, we had the pharmaceutical companies for a hearing, and they blamed the PBMs. So you got to stop the finger pointing, and that's why take the secrecy out of all this pricing, and make sure that we know exactly how the process works. If you really want to see how complicated the PBM role is in all this between making of the drug and research on the drug and getting it to the consumer, last week, I believe, Wall Street Journal had something online that showed how complicated this process is. People ought to take a look at that. You can't understand it, and we ought to be able to understand it. And for instance, the federal government is one of the biggest, maybe the biggest purchaser of drugs in the entire country. And we're spending a lot of taxpayers' money, and we ought to be responsible for spending, and you ought to know what gets into the price.
I do want to get into another issue, and you alluded to it earlier, just the federal government being a large purchaser. One of the big programs is Medicare Part D.
Yes.
what substantial changes could be made to Part D, other than the rebate rule, that would actually, because I think a lot of people would agree Part D has a lot of wild incentives and weird setups within how the benefits are designed.
Yeah.
What substantive reforms could be made there and actually put into law? Because a lot of people are miffed about this.
Both to save the consumer money and to save the taxpayers money. Right now, there's a big push to get through the donut hole and get into catastrophic coverage.
Right.
Because that's where the taxpayers comes in. So both the
Taxpayers cover 80% of catastrophic. The federal government pays for a large portion of it.
Yeah, and the more you get in it and the higher price the drugs is, the more the taxpayers are going to be paying. Mm-hmm. And there's an incentive for the insurance companies and for the pharmaceutical companies to get people into catastrophic benefit, very soon. And so get them through the donut hole. So we want to take away that incentive by having the insurance companies and the pharmaceuticals pay a greater part of the cost, put a cap on what out-of-pocket expenses would be, and save the taxpayers money in the process.
So
but the whole idea is to do away with the incentive to quickly getting people into the catastrophic.
Just to be clear, you're basically talking about introducing pharmaceutical manufacturers having to pay some of that percentage in the catastrophic. Currently, pharmaceutical companies pay nothing. And you're suggesting, hey, how about we propose something where they pay a percentage now?
Yeah.
I'm sure they're going to be thrilled about that.
Well, of course, but then it's just the opposite today. They're incentivized to getting people quickly into catastrophic by the more expensive drugs, as an example.
Okay. We will have to leave it there. I appreciate you coming on, Senator Chuck Grassley.